Welcome, everyone. My name is Adelina Comas Herrera. I'm the director of the Global Observatory of Long-Term Care, and I'm delighted to welcome you all to today's webinar. I'm going to start with a very brief introduction about the observatory in case you are new to it, and also so that those of you who are already members, so that you know what we're going to be doing next. And I'll quickly share my slides. So the Global Observatory of Long-Term Care is a platform to exchange knowledge and learnings about long-term care. It's all about how to improve care systems, and it's part of the International Long-Term Care Policy Network. And we're looking at the key challenges across the world and how different countries and localities are addressing them, and share research evidence and facilitate collaborations, and it's open to everyone. You can share your work through our blogs, through webinars like today. We're also publishing country profiles on the long-term care systems in different countries. And the heart of the observatory are the interest groups, like the one today, where they organize webinars on particular topics or parts of the world or even methods. And they also share relevant publications and resources. We have quite a few webinars coming up, including some on qualitative research methods. Got another one from this group on that I'll show you in a minute. We've got webinars on pain management, on care in the community in Spanish. We've got some on quality management, innovations in care. And on the 28th of November, we're going to have a whole day event that I'll show you in a minute. And we're also looking now at AI and whether it can help us with qualitative research. The next webinar from the GOLTC Care and Social Protection Southern Africa Interest Group is on the 7th of November, and we will be sharing the link with you on how to register. So I hope you join us for that as well. And on the 28th of November, we have our International Day of Care and Support celebration. And this year's theme is on changing the narrative on long-term care. And if you want to join the observatory, if you're not a member yet, you can do so by filling in this form. We've put in a QR code and also the link, and as we'll also put it on the chat. And I think that's all from me, and I'm handing over to Elena from the interest group.
Thanks, Adelina, and thanks, Adelina and Naz, for facilitating this seminar. I'm very excited to host and facilitate also the seminar today. Just a brief introduction. We are the Social Protection and Care in Southern Africa interest group. We started over a year and a half ago. Obviously, as the name suggests, we bring people together working in the region, on the continent, and thinking about elder care, social protection, and needless to say, other related issues. Today, I am very, very excited to have some of my favorite people talking together in conversation about the much neglected area of home-based care in the region, but in other parts of the global south. We have Pariah's leading speakers, Carla Giacomin, if I'm pronouncing that right. Carla, apologies for that, who will talk about the fantastic work in Brazil, the Programa Major Cuidado, I'm not even, and talking about the health and family caregivers. We have two colleagues from NPOs in South Africa. We have Famada Shimam, who many of you already know, talking about home-based care services and lessons with working with family caregivers, who she'll introduce herself as well a little bit later. And we have Muzwa Madodo from GAPA, another NPO here in Cape Town, doing peer-to-peer kind of home-based care provision and support for older persons in informal settlements in Cape Town. So I'm not going to take any more time. We also are joined by Peter Lloyd Sherlock from Northumbria University, who has worked in both countries quite extensively in Brazil and South America, as well as South Africa, to kind of summarize some of the lessons he's learned, but also what we've heard from the three fantastic speakers. So without saying any more, I'm going to hand over to Carla. We have a very tight time, so I will stop you after about 8 minutes, Carla, because we are going to make sure there's time for questions. Okay, thanks, Carla.
Okay. Well, nice to meet all. I am Carla from Brazil,
and I am the president of Brazilian Care Association, and I should show to you the effects of Programa Maior Cuidado on the health of family carers, please. So the Maior Cuidado is a social program. It's an integrated care, and it adopts an unique cross-sectoral approach in Latin America, jointly developed and managed by municipal health and social assistance policies. And it integrated caregivers into local teams to meet the broad needs of older adults and their families. And it considers also the entire socioeconomic context. It considers the broader circumstance of older adults and their families, and not just the health and the functional status of the older adult. And it is especially relevant in communities where many families face multiple problems and deprivations that affect the quality of home care. Please. There are some inclusion criteria, and we have an evaluation process and a follow-up and support offered by the social assistance and health teams for reviewing existing case, prioritizing new potential participants, and provide ongoing support by trained family care workers. Please. So this professional support offers families support from social caregivers. They work 40 hours a week and serves 1 to 5 families and provide 10 to 20 hours of weekly support as needed. But there are gender norms, and previous research has shown that PMC directly benefits seniors, reduce unnecessary use of health service, but in Brazil, usually we think that women should care. And so the program is transforming a little bit these gender norms. Next. We applied a mixed method design with qualitative methods and quantitative methods. I will show you some results of the qualitative methods, please. And the main results are 3/4 of caregivers are women. 1 in 5 caregivers are aged 70 or more. We are focusing on gender and caregiver experiences. We can say that PMC, the Programa Maior Cuidado, reduces overall care burden for family carers, but it's not stop them, and it's not able to completely exclude the burden. And PMC helps carers engage in paid work in some case. And it's relevant because they can have more money for their family. And over the past year, we gathered extensive qualitative data from interviews and focus groups with family carers and PMC staffing, focusing on caregiving experience and change after joining PMC. And health issues stand out as a major theme. Please. So I can say about the PMC and physical demands of caring. Many older people in PMC have limited mobility and need help with daily tasks. Assisting them demands strength and care, which can be difficult for older or unwell caregivers, risking injury. So a PMC caregiver describes the difficulties of a frail man helping his wife Beth. She's paralyzed down one side after a stroke and needs support to walk, get up, bath, everything, sitting, rolling over. He's very skinny and can't weigh more than 60 kilos. He pushes her around in a plastic chair, and he has to lift her and off and on to use the toilet. Please. A woman caring for her father who is obese has limited mobility and is unable to bathe independently, explains. I am in a lot of pain because of the bursitis, in my back because of the lifting. The PMC carer helps me a lot to manage my father's weight, as we are able to lift him together. So we managed to do it together. It makes a big difference. I'm not so frightened, stressed, or worried when I am bathing him. Next. Another aspect is the PMC and access to health services. Many family caregivers in PMC provide continuous care, limiting their ability to leave home and access health services, which often leads to untreated health issues. So a PMC carer says the daughter wasn't in position to go to the doctor. She never smiled. It was like her father was like a big weight on top of her. She had her own health problems, like hypertension and some mental health issues. In the case of an older male caregiver, he could never go out alone before PMC because his wife would keep having these crises. So he would have to take his wife with him to the health center. It's quite far and the way is steep with steps. They live on the third floor and it's difficult for them to get down the stairs. There's a real danger of them falling. And many family caregivers took advantage of this time PMC carers who are in their homes to resolve their own health issues. For example, since the PMC carers start coming, I've been able to go out for health visits, to have some tests, and get my health sorted out. I'm feeling a lot better, especially because I have a problem with my thyroid. It was making me feel tired absolutely all the time, constantly sleep, but I couldn't sleep or do anything about it. And I was in a lot of pain. So I went to the health center. They ran some tests. I took the medication and now I feel so much brighter. When I wake up in the morning, I'm ready to get on with things. Please. And mental health. Family caregivers' mental health is greatly affected. All this generates an overload for the daughter, not including the suffering of seeing her mother in this condition, an illness that she knows is progressive. The daughter tells me how painful this is for her, and she always has to be multitasking. She needs to think about her job, so there is enough money to cover the family's needs. Because she's the head of the household with 2 young kids, and she also has to take sole responsibility for her mother. The emotional toll is much greater than the physical one. Worrying about the house, the kids, how to sort out her mother's medication, plan her day. Please. Receiving regular visits from trained caregivers for 2 to 4 hours a day did not entirely take away this stress, but at least offered some respite. And they also would use this time as an opportunity to do other jobs and chores. So there are some examples about how PMC helps family to cope with mental health. Please. And for example, one woman commented, I am so exhausted. And so the first thing I do when the PMC carers arrives is just lie down and doze for a while. Another example, when the PMC carer is here, I just leave my mother in her hands, but I'm always around and the carer and I talk a lot about things. She's someone I have come to trust enough to talk about sensitive things. This helped me feel calmer because she understands what I am going through. I know she wants the best for me and my mother. It's really nice that she understands our situation. Please. So, PMC is not a panacea. PMC serves families with older people needing major care, targets deprived neighborhoods with poor health, reduce physical injury risk from lifting seniors, improves access to health service, provides psychological benefits through respite, and family caregivers work unpaid, needing health protection, supports reducing residential care admissions due to caregivers in illness. I'm so proud to be here, and I am a little bit fast, but I thank you for your attention, and I am here for any explanation necessary. Thank you.
Thanks so much, Carla. That was fantastic. And again, congratulations on all the work you do. You do so much. I know you only had 8-9 minutes to talk about it, but we're really huge fans of your work on this side of the world. So well done. And it's great to hear a narrative that's not focused exclusively on paid employment for family caregivers, that tells us about other ways in which respite can help. So thank you for that, to also broaden the narrative. Thank you for that. Okay, I'm going to hand over to Famada. You've got 6 or 7 minutes. So yeah, the floor is yours.
Okay, thank you. Thanks, Alina. Are you guys hearing me?
We hear
are we
you
good?
well. Yeah.
Okay, perfect.
And
Okay,
we
and
can
you've
see
seen
the
the slides?
Yeah.
Okay, perfect. Hello, everyone. Thank you so much for giving me the opportunity to share with you the neighborhood care model that we implement in one of our communities in Durban, South Africa. So I'm just going to give you some context because it's so important to the model that we're using. And contextualizing this, it's a coastal community on the outskirts of Durban where the air once carried the putrid smell of the refineries. We have 2 refineries in the community, and the streets in this community still echo the complex legacies of apartheid and industrial decline. But within this context, I'm going to call it a care revolution, is quietly unfolding, because I think it is revolutionary. This is not a story of grand institutions or sweeping policy reforms. Instead, it's a narrative about people. It's about Christine Labby, a woman who, in her late 80s, cares for her daughter who is living with advanced dementia. So it's really questions about who's the caregiver. It's about a young man who finds himself navigating the delicate balance between being a boyfriend, a caregiver to 3 children, and also caring for his girlfriend's grandmother. It's about the 26 churches that exist in the small 3.8 kilometer squared area. So within the small proximity, 26 churches. And this is the story of how TAFTA transformed a crisis of unmet needs into a system that works, and that's really grounded on a profound truth that caregiving is not a solo performance, but rather it's a symphony, a community symphony, and everybody needs to come together. All right, so let me quickly go through the slides before Lena tells me my time is up. So this is the community I'm talking about. So you can see the refinery at the back. And it's a complex community. So you have kind of formal, what looks like upmarket housing right next to what looks like low-cost housing. But there's a whole complex issues that's working within this community. And this is one of my favorite people, Christine Labby. And perhaps this is the first lesson that I want to talk about. It's the gift of respite in small measures. And Carla spoke about it in her presentation as well. Christine Labby's story illuminates the first crucial lesson of this model. Formal caregivers exist not to replace the informal caregivers, but to support them. When a trained caregiver arrived to work with Christine's daughter, they were not so simply providing care to someone living with advanced dementia. They were giving Christine permission to step away, to tend to herself, to reclaim fragments of her autonomy in a life consumed by caregiving's relentless demands. The power of this respite lies not in its duration of just 1 hour, but in the regularity and the reliability. 1 hour may seem insignificant, but to someone who has not left their loved one's side in months, it's a lifeline. It's the difference between sustainable caregiving and collapse. And it gave Christine a chance to wash her hair and look beautiful. The next lesson is about the hidden caregivers and the many roles that they take on. The second lesson emerged from a very unexpected place. A young man, this man in the picture, who was simultaneously a boyfriend, a caregiver to 3 young children, and the support person for his girlfriend's grandmother. Here, the complexity of modern caregiving reveals itself. Caregivers do not exist in single defined roles. They juggle competing responsibilities, navigating the emotional and practical demands of multiple relationships. Moreover, this young man faced the challenge that speaks to the importance of dignity and cultural sensitivity in care. He was uncomfortable bathing his girlfriend's grandmother, and we can understand his discomfort. The discomfort is not a failure of compassion, but it's a recognition of boundaries and appropriate boundaries at that. The arrival of a formal caregiver solved not just a practical problem, but an emotional one too, allowing him to support the family in ways that felt appropriate while also ensuring that the grandmother received care that honored her dignity. And I think that's so important as well for us to understand the complexities of that. Lesson 3 is, I call it fresh eyes and renewed relationships. Perhaps one of the most surprising insights from the program relates to what is called caregiver fatigue, and Carla spoke about that as well. The drudgery of caregiving, the repetitive tasks, the mounting frustrations, the emotional weight of watching someone you love decline can poison the relationship between the caregiver and the care recipient. Both become trapped in patterns of irritation and resistance. The introduction of a different caregiver brings something precious, a change in the dynamics. A new person arrives without the accumulated resentments, without the history of small conflicts repeated 1,000 times. They bring fresh patience, a different approach, and sometimes even joy. Imagine that. This variety in who provides the care enhances the quality, not through superior skill, but through the simple alchemy of human diversity. So it's in the simplicity that the magic lies. The lesson 4 for me is care for the caregiver is not optional. And this lesson comes from an adult child living with mental health conditions who is serving as a caregiver. So the lady in the bed is cared for by her adult son who has a mental health condition. The formal caregiver's visits did more than support the older person. They helped this caregiver maintain his own clinic appointments, attend to his own mental health needs, and sustain the capacity to care. This reveals a fundamental truth. Supporting family caregivers is not a luxury, but it's a necessity. When caregivers collapse, care systems collapse. Investment in the caregiver support is therefore an investment in care itself. Okay, the fifth lesson is a recognition of the invisible networks. I'm going to go quickly, Alina. I can see you judging me here. But this is important. What makes this model really relevant is its recognition of care as a distributed network rather than an individual burden. In mapping the community, Tafter discovered the invisible infrastructure of care that already existed, neighbors that prepared meals, religious organizations that visited on a Wednesday, local soup kitchens, social workers, and those 26 churches that had their own outreach program through their social investment. Each one of these care partners represented a thread in the safety net that, when woven together intentionally, could hold more weight than a single strand. So it's really about the strength of the collective. Just want to go on to the next one. Oh, this is one of my favorite people. She's 100 years old, blind as anything, But every morning, Isadora, our caregiver, would go in and sit with her while she had breakfast. And that's her daughter who's standing there with the purple cap. And she was really grateful that we were able to support her mum. The last one is geographic proximity matters. In terms of the neighborhood model, we mapped out where the older people were. We looked at unemployed women that had entry-level caregiving, some entry-level caregiving certificate course. And then we designed it so that they could walk between the houses. And we realized this geographic proximity made the whole system work. So in summary, quickly, the lessons: formal care augments and does not replace informal care. Respite comes in small, bad spelling there, but regular measures, multiple roles of the caregivers, and the whole issue around dignity and appropriate boundaries, the variety in the caregivers, supporting the caregiver equals supporting the care recipient. And for me, what's most important is that care networks exist. We mustn't assume that there isn't any care at all. Communities have survived over the years, and they will continue to survive. So we must add to that natural evolution. And some of the lessons that I share with you guys is start with mapping. You know, what's there, who's there. Embrace the diversity in the care partners and provide multiple forms of support. I know that's easier said than done, but keep it simple. Design for the domains of well-being. And so at TAFTA, we use the Eden Alternative, and one of the domains of well-being is joy. With all of our caregivers, that's one of the things we say to them: inspire joy wherever you go, and then adapt to the community context as well. Thank you. That's it.
Well done, Fem. I mean, that's a fantastic demonstration of the phenomenal work you're doing with your partners at the local level. And needless to say, you managed to get through all of that in time. It's so exciting to hear about this work and also how it links to the next speaker, where we're doing community mapping in different parts of the country. We're going to move over to Cape Town now. Muzwa Madoda, I'm going to introduce you, and we're at the beginnings of this work. So the connections between Fem, what you just explained and what you just showed, and what we're beginning to do is exciting. Muzwa, the floor is yours.
Thank you very much. Okay, great. So yeah, good afternoon, everyone. Zwamatota is my name, as Elena has mentioned. Based in Cape Town. Khayelitsha is our organization called GAPA, which stands for Grandmothers Against Poverty and AIDS. Just briefly, the history and background of GAPA, how it came to be. GAPA was founded, after the outbreak of HIV and AIDS in South Africa, which was like in the early 2000s. At the time, where the president then, they were still trying to grapple and understand what is this HIV, and also the rollout of ARVs were also, not as efficient, or they were not as swift, because they were still trying to make sense of this. But during that period, a lot of people were losing lives. The grandmothers then had to step up, being their mothers to the kids that were left by their kids. So a research then that took place in Khayelitsha, trying to understand how does areas like Khayelitsha are making sense of this and understanding, and how are they trying to make sense of HIV as this outbreak and the pandemic. Meanwhile, the ministry and government are still trying to see how they can roll out HIV prevention tools and awarenesses and so on. So in that process, as I said, GAPA then came to be because these grandmothers, as a research was trying to make, the researchers were trying to make sense of how then in Khayelitsha, which is an informal settlement of Cape Town, historically, I think Famida touched on this. I mean, whenever you talk about South Africa, you'd always touch on that legacy of apartheid and the displacement and how people were moved from certain areas to certain areas through Group Areas Act and so on. So Khayelitsha was part of that as well, where it's, as you can see in the picture here, highly congested, a lot of slums and just a lot of challenges in the area. So the researchers were trying to make sense of the impact of HIV in that region. And of course, these grannies who came together to give and share their experience, it was from that then GAPA was born. And amongst many things that GAPA has been doing, has been more like a peer-to-peer support. And some of the programs that are coming from how the grannies themselves are developing and coming up with methods of how they can somewhat navigate all these challenges whilst they are also taking care of their grandkids. If you can go further down and to I think there are some pictures there that can also illustrate the work that is done at GAPA on the peer-to-peer level. So GAPA, as you can see on these pictures, so GAPA has 4 programs, and these 4 programs are the one that in which the grannies themselves are able to be empowered and make sense of life, as it were, and the challenges thereof, without also being disempowered by the socio-economic conditions they are coming from. So of the programs that we have the food gardening, which the grannies themselves are working in that food gardening. We also have what we call ikupa. So ikupa essentially is a Xhosa word that the grandmothers themselves came up with, that let's call this part of the psychosocial support program, ikupa, where they lean on each other. Ikupa, as I said, is a Xhosa word which literally means to cough out or whatever, or to vent. So they would create a safe space whereby they would share their challenges with, of course, the guidance at times, or with the observation of our occupational therapist. At times would have a social worker in place, but the grandmothers themselves would lean on each other as and when they are sharing what is bothersome, what is happening at home, what they are dealing with. And from that experience, we can also develop a program of intervention as to how do we intervene, what can we do. But more than anything, what for me has been a learning experience in this ikupa is how the grandmothers themselves would always show up for each other. And also, one of the skills they learn at GAPA is the sewing and crochet, which is one of the programs as well. That is also taught by the grandmother to other grandmothers as well. So GAPA has all around Kailicha, there are clubs. And I think I'm happy that there was also this mention of mapping as well. So there are these extension of clubs, but GAPA being the main host, or the center where all of the trainings would take place, but the grannies live around Kailicha, and they have clubs around Kailicha. So then the health club, or the main training center, would be GAPA, the center, where they are learning the skills, as I said, of crochet, sewing, and all of those kind of skills. So through this mapping exercise, we are looking at in ways of intervention, and how we can also make the experience of the grannies more meaningful, also understanding where they are and what are the limitations in areas where they are at, so that we can offer a more holistic intervention as far as the approach or the of assistance is concerned. But I mean, again, speaking on the ikupa and also the peer-to-peer support, how it shows up in action, how it plays out, is the grannies themselves who would come to GAPA on a particular Tuesday to learn these skills. Then they take them back to their different clubs to teach other grannies as well, be it the gardening, be it the sewing, be it the skills that they've learned about how to deal with challenges that they are navigating. Because when they share, one granny who shares the experience, the other granny would have dealt with that before. And so from that, they are able to advise each other and also take that to their clubs as well. So GAPA is operating using that method and that approach. As much as you are seeing this man here and talking about grannies relatively young, I mean, I'm just a manager there, honestly. That ship is able to sail on its own, because the grannies, the only impediments would be perhaps they can't get to certain spaces, they can't articulate themselves in English, as it were. But I mean, in Xhosa, their native language, they are professors, you know, and they know exactly what they want and how they want it done. And at times I would also be called into order. Nzoma, you are still a baby. This is how we do these things. This is the experience we have. So sometimes the limitations with education, as it were, can go as far. But the experience from the grannies who have lived through apartheid to this dispensation, and the spirit of resilience that they have. And I mean, they have a slogan at GAPA where they say, together we are stronger, and they've embodied that, and they have come to understand, even so, more so with the philosophies of Ubuntu as well, that there's nothing you can do without the other. And also, hence, I also appreciate these platforms where I also get to learn about other experiences from other parts of the world, because again, it speaks to the ethos and the objectives of GAPA, about Ubuntu, about also how we can collaborate with other entities that does this same work. But like I said, I'm 7 months at GAPA, and it's been so much learning for me, coming from a different walk of life, being in this space. And I also want to mention it here, the appreciation also to Prof. Elina, who always rope me into some of these talks and these conversations that are happening on the elderly care space. But one thing I can say with GAPA, you know, you always learn something new every day, you know. And what has been exciting for me, and which is a turning point, is the mapping exercise that we have embarked on, because that mapping is more like a census, also to locate our beneficiaries where they stay, and which will also inform us how better we can be of service to them. But like I said, this train of GAPA is been existing for over 24 years now, with little funding, you know, which has been quite a problem with a lot of entities, I can imagine. But for over 24 years, they've been somewhat making it. And when you get to that space, you feel it. When you hear the singing of the grannies, you feel it. We have had visitors from Canada, from California as well. The grannies will come. And when they come to the space, the singing and everything that happens there, because it's a big part of GAPA, when the grannies sing, it's like they sing their issues and problems away, and something else comes to the fore. So yeah, I hope I didn't take much time, but that's who GAPA is in a nutshell. I mean, you know.
Thanks, Muzwa. It's fantastic. It's great to hear more and more, and for everyone in the room to hear more about the fantastic work that exists, predates you, but also the work that you're doing there as well, and supporting new initiatives and supporting, all the grannies that are there, but also learning from them, most importantly, as you said. So thanks for this. And I think the connections between, the work and what Famada has shared, but also importantly, what Carla and others have managed to achieve is a real trajectory of forms of home-based care, or support at least, in complicated settings and different contexts across the global south. So I'm not going to say any more. I'm going to hand over to Peter. I hope Peter is able to connect and hear us. Oh, I see him there. Hi, Peter. I'm going to give the floor to you now. Go ahead. Adelina, Nas, I'll take your lead on this, whether it's a bit complex, it's a bit too muffled, right?
Yeah, I think maybe it'd be best did you want to take on the discussion?
Yeah, absolutely. Sorry,
Okay.
Peter. If you do hear us, we're just going to move on a little bit, just for the sake of time. We have quite a few people in the room.
Ellen, I also suggest that maybe, Peter, if you want to type in the chat some thoughts and questions, and then we can also read them out for you.
Exactly. Okay, I hope Peter got any of that. So what we'll do now, I think we can open it up to everybody in the room. I know there's many from South Africa. I don't know if there's any burning questions, but if there are, raise your hand either that I can see or virtually raise your hand. Rob, I see one question there. Any other questions? I'm going to take a round. It's going to be easier to do a round. Any other hands up? Okay, Rob, you go ahead.
Sorry, I didn't have a question. I thought you were asking who's from South Africa. Sorry, Lena. I'm just learning.
Fine. Okay, so Veda has asked the question, if I see it properly, can you tell us more about the mapping project? So just for background, Ms. Wad, do you want to take that one?
Sure, May. So the mapping project came about. In fact, of course, the family care is our partner in this mapping project. There, so when I got to GAPA, as I said, I've been with GAPA for 7 months now. So when I got to GAPA, one of my, because I mean, whenever we present about GAPA in a lot of spaces, it would like we are serving over 600 grannies, 700 grannies, the numbers varies, And so my curiosity was to learn, like, where are they exactly, where is the data that actually, backs this? This is a number of grannies that we have. So, um, the mapping is more like a census, really. It's a census project where we are trying to locate where are our grannies are at, because we do see those who come to the space every now and then. But I mean, the idea for us, and when I spoke about this, and of course it was elevated to a more research, big level, is to actually identify what is available at their disposal, what are their needs, so that we can better cater for them. So in the areas where they live, what are the impediments that they deal with on a daily basis that, somewhat is not allowing them to access any opportunities? Do they know where's the police station? As and when something happens to them, what is their first point of call? Where can they go? And how do they travel from where they live to the center, GAPA? What are they dealing with in that? And also for us to know what are the activities that are happening in those clubs, how often do they happen in the clubs themselves, and how we can also take services to them. What will be the challenge for us to do all of those things? So the mapping exercise has been, as I said, is quite exciting for me, because I was just thinking about how many grannies we have, but there's more into it. It also would help us it will also inform the programs that we do as well. How are they aligned with what are the needs of the grannies themselves? So we have developed questionnaires, of course, and we are in that process where we're trying to also get from the grannies themselves. Do they still feel GAPA with its methods? Are they still being served, or what is missing? So the mapping exercise is essentially to assist us with that, and also to be able to digitize things and put it on the website. If you click on GAPA website, you should see how many clubs they are at, because they have different names. And if you click in that particular club, you should be able to see what they do, what days of the week they meet, and yeah, that's essentially what. Yeah, thank you.
Perfect. Thanks. I mean, it does beg the next question, for example, that I think I'll, that's the early stages of mapping to find out, like Ms. Wall mentioned, where people are, or what impediments do they have to their daily lives, and what are the existing care infrastructure on the ground where they live that can be helpful. But to Famada and Carla, I mean, you're further down the road, right? You've got existing home-based care programs running. I mean, in a nutshell, how did you move from having nothing potentially, or and I'll put it to Famada first, and then Carla, I want to hear from you as well, to having these large-scale programs, or large enough, maybe differently scaled programs in existence?
Yeah, I think one of the aspects of the project that works really well is that it naturally evolved. So there was a need. We knew that there's an increasing number of older people, and we saw that community people would tell us about older people that required help. We have a high unemployment issue in that community, like the rest of the country. But also it was about people approaching a facility that we have in the area to say that we're dropping off our CVs. If there's an opportunity for employment, can you employ us? And so it naturally evolved. So we brought together a number of different stakeholders, and we said, okay, we have more people than we can service. And the natural thing to do would be to go and find funding and increase our institutional care. However, we decided to take a different approach, and we said, rather than bringing people into the facility, what if we took care into their homes? What would that look like? I must admit it wasn't a straight line. We went back and forth trying to understand how we manage this, how we map it. We also had to match personalities. So the lady that I showed there, Isadora, she's larger than life. I love her to bits, but she's not everybody's cup of tea. So we had to match the personality with the older person in terms of what was needed. So it took a lot of intentionality in terms of how we got the program together. But there was a willingness by various people to say, we want to get this right. And there was support from that. So I think the other aspect of it is leveraging off the reality that everyone has a role to play. Very simply, what we said is, if the person requires 24-hour care, who are the partners that's providing that care, and what slice of this pie does TAFTA have to take? We don't have to take the whole thing, just an hour of this entire slice, because an hour is covered by the neighbor, an hour is covered by the nurse, by the church. So there were different players, and then understanding that it was a joint responsibility. So I think the starting off point is to change our frame of reference. It wasn't about expand your institutional care, but rather look at how do we get care in the community, and then find like-minded people that you could have conversations with.
Thanks, Ben. Carla?
Yes, Programa Maior Cuidado started 15 years ago. So we have a long way to learn and to share experience. We have some criteria, and both policies, social assistance and health, should point this criteria, and only if the person fulfill the criteria for health and social assistance, it could be admitted to the program. And during these 15 years, we developed many tools, and now we have some tools to monitor how this care is going on. And we have also meeting together with both policies to discuss and to discover some people. So how could people come on? By the community health workers that are in the territory, or the social assistants, because they are on the territory too. Okay, so we can find some people, and we discuss and we point the criteria, and if it is possible, we can get in.
Carla, you make it sound very easy. Although there's 15 years of hard work in there.
Yeah.
It may require longer conversations. Are there other questions? I don't see any in the chat. I see a comment about mobility, which I want to acknowledge, and I think all speakers will recognize the challenges of, and probably everyone in the room, of mobility challenges, particularly in informal settlements. Not just mobility challenges, but challenges with regards to navigating security, human security, violence, drugs, and many other transport. And these, I think that's why hearing from Carla is really exciting, because I think in the areas that she's worked, there are very grave similarities. I mean, they're very closely aligned kind of contexts. And perhaps, Carla, we can hear from you about how you navigated those types of insecurities that exist on the ground.
Yes, we use a cover, so we are recognized by the community, and we have free, I can see a free card to go, and we are very respected by the gangs. Unfortunately, there are. And another thing, I could not talk about freedom. People experience freedom because the caregivers, the family caregivers, are completely, they are feeling prisoners inside their homes because they can't leave. Sometimes we arrived and some people said, there is 1 year that I am here and I can't go anywhere. Freedom, respite, another kind of the emotional support. It's very, very necessary, and it's really occurs because caregivers, they are trained, but more than this, they are human. And so they can share emotions with the people, with the families. So it's very nice, and it's hard to measure. We can't measure how much feelings we are talking. So I think it's very nice.
Carl, if I may ask, I don't want to hog the floor here, but I don't see any hands. Oh, there's a hand. Did I see a hand? I am curious to know how you got the respect of the gangs.
Okay.
But I think is there a hand? Naz, is there a hand up? Or is that a mistake?
There's no hands up. But
Okay.
people are writing in the chat if
Yeah. Okay.
That's always
Yeah.
the approach I take. I always just throw it in the chat, and then we can discuss it if there's a lag, or I'm happy for just to sit there. I'm always up for a chat.
Okay, thanks, Janine. Sorry, I see you now. Sorry, I didn't make connections. So perhaps, Carl, you can tell us how you got the respect of the gangs. I am curious, and then I'll move over to Janine's comment.
Okay. Last year, I received here a filmmaker from Holland, from Netherlands, and he was very surprised because one thing is we can talk about slums, we can talk about poverty, but it's completely different when you are there. So you can see, you can smell, you can touch, and in these slums, there are many dogs. They are making surveillance for the gangs. Dogs, the animal, okay? And when we use this cover, this clothes, all the doors are open, so we can circulate on the floor, okay? And why does it occur? Because they believe we are not spying the activities of violence, okay? And sometimes we cares for them, for their parents, their grandmothers. So that's why it works.
Thanks, Nada. I mean, Famada, I think the comment from Janine might, if you're willing to respond, she talks about how the next generation of carers, we have a rising aging population. Home-based care would potentially, require quite a number of home-based carers. And she argues or states that people will be snapped up as they become qualified, they'll be snapped up by Western countries to close the gaps they have in their care kind of economy or whatever. So will this be another lost generation? Perhaps you can share from your experience how it's gone.
Yeah, I think that's the reality. As younger people have aspirations to progress in their lives, going overseas seems to be an option, and there are pathways for that to happen. So I think we have to build that into the plans. We can't bury our heads in the sand and say this is never going to happen. But South Africa is unique in that we have a large population of young people who are not employed. And not everybody wants to work as a caregiver. That's the other thing, I must put out there. It's not the most sexiest of jobs. However, people are looking for pathways to be able to do meaningful work. When I look at the people who are part of our home care program, not every one of them are younger people. Some are middle-aged and went through some difficulties. They're looking at ways to access the economy. Many people are still in the informal economy as well. So perhaps I'm going to take a more optimistic view and say that we probably don't have as big a workforce issue in terms of care in South Africa that perhaps other countries have, because we have a high unemployment issue anyways. So people are willing to take anything. And we must create meaningful work. And that's one of the things that I didn't get to share about our care model. We started off, and it's naturally evolved, and it's an iterative process. It's not a straight line, as I said. So when we started off, they came on as volunteers. They wanted to volunteer. Then we looked at stipends, and we realized that we must pay fair wage. And so we started a process of understanding what does fair wage look like. And then we brought them onto our payroll. But obviously, this adds expenses. So we had to look at a model that was sustainable and that was fair to our caregivers as well. So it is a process that we've gone through, but each step of the way, it's about having conversations with all of the care partners, the older people, the caregivers themselves, but also the other care partners that we have. The Department of Social Development is a care partner. Granted, they haven't increased our subsidies. However, there is some funding that we access through the department as well. And Alina, the other is the grant in aid as well, that provides some kind of support. So I think we have to look at all of the different pieces of the puzzle and make it make sense in our context.
Well, on those wise words, thanks, Fem, for that response. I think I see the clock, and I see we are coming to a close. Adelina, I want to first of all thank everyone for joining. I know it was short and sweet, but it's a flavor and a taste of the things happening here and elsewhere. And I think there's been a range of websites shared in the chat that you can go to find more out about the different programs or whatever. So I want to thank again everyone, presenters specifically, but also Adelina and Naz for facilitating this. Adelina, I'll hand it over to you.
Just to say a very big thank you from me. I learned so much, and it's just great to see the detail of how these things work, and even some pictures. I really, really appreciate it. And we look forward to the next webinar of this interest group on the 7th of November. So, and we'll hear about programs in Kenya as well. So, yeah, have a good rest of your day, and thanks again.
Thanks, everyone. Bye-bye.
Thanks, everyone. Bye.